Hi guys, it's Dr. Liv here, presenting the first tongue tie seminar that we've done. This seminar is basically going to be a very similar presentation that I made to our patients in the practice about 2 weeks ago when I was on my last week before maternity leave. So I know Dr. Ant was present, so perhaps a lot of this stuff will be a repeat, but in saying that, it's really important to, I guess, always just reaffirm how important this information is, and also to really understand tongue tie. Just a bit of a brief introduction for those doctors, particularly up in Mackay, who may not be aware of my training in tongue tie. I guess, personally from experience, this was definitely something that probably about 6 months ago really took my attention, or maybe not six, more like 8 to 12 months ago, when I first met a really great functional dentist, Dr. Stephen Lin. I realised that oral restrictions in children are so high and prevalent, and really that I needed to know more. I also began seeing a lot more in my practice, and that also too sparked, I guess, my interest to find out the best information that I could, do the best courses that I could, and also to hopefully impart some knowledge on both my colleagues, but also to obviously my patients and of course their parents or guardians. So I'll tell you a little bit of history about where I've come to with tongue ties, I guess, and lip ties and buccal ties. I guess this is something that I first learned about in retained neonatal reflex seminar probably about 10 years ago, in conjunction with the juvenile suck reflex and also to the rooting reflex. And of course, its impact on breastfeeding, solids, speech, etc., all the things that we've come to know about those reflexes. Back then, I really only knew that they were really snipped. When I say snipped with scissors, I didn't really know much about lasering. I didn't know much about any of the other implications. I didn't know really where I sat in that, or obviously the work of a body worker. So there was a lot of ifs and buts. So I guess I saw them in practice, and had mothers talk about them, particularly in breastfeeding. But like I said, about 6 to 8 months ago, I guess my real sparked interest was with a young girl who was 15, with a really severe speech impediment. And when I was assessing her TMJ, and particularly when I got her to open her mouth, I was bamboozled by what I saw. And it was literally the thickest tongue tie I think I had ever seen on a child, especially to 15 years. And again, just was dumbfounded that this poor girl, who clinically, when you look at her history, was an emergency C-section, mother took folic acid in pregnancy, also too just really didn't breastfeed, couldn't, was told that mum had low milk supply, was a very unsettled baby, reflux colic, all of these things. And then, of course, when it came to speaking, she didn't. And when she did, there was a severe lisp. So I started that journey by referring on to Dr. Stephen Lin, who assessed it, snipped it, and the result that I saw after was remarkable. Pretty much this lisp went away. It was incredible. Now, before that, I'd obviously done all the body work to prepare her mouth and jaw for the tongue, and then for the tongue tie release, or the frenectomy, which is the fancy word for what we call a tongue tie snip, the laser. And then the amount of function that it was in this girl's mouth was insane. It was, quite remarkable to see. So from then, I went to go and do some seminars with a group of dentists called MyFocus. And those two dentists, one of them is Dr. Donnie and the other one's Dr. Dan. Both brilliant clinicians, and also two brilliant dentists. And they're really paving the way for myofunctional dentistry, and also to, again, understanding oral facial restrictions, and also to then in just really getting the whole team environment up and happening, and also to utilising everyone's skill base, which is phenomenal, because as we know in our profession, sometimes that can become really overshadowed. From then, there was a brilliant seminar down in Melbourne I attended, and then I heard of the Tongue Tie Institute, which Dr. Dan is part of, and another brilliant lady called Dr. Marjon Jones, who actually founded the Tongue Tie Institute, and I can recommend solely on doing any of their seminars, but particularly anything that is led by Marjon. She's brilliant at what she does. In my experience, she's probably the number one in Australia for phoenectomies, and also to lips and pupils, and to be honest, knowledge around that. For those guys in Mackay or our other practices, just make sure that when you are working with these dentists, and again, talk to me about the types of things that you're looking for when you're speaking to a dentist that does these releases. Because since going to Marjon seminars, there's a lot more things that need to be taken into account. For example, when a child is going in for lactation purposes, to have these assessed, 110% there needs to be a lactation consultant who's present, who actually understands these oral restrictions and also understands the impact that they have on breastfeeding. Okay, so let's get on to today's seminar. So if we look at just the functions of the tongue, now this was something that Dr. Dan really explained to me, and I thought this was such a great way to look at it. So basically, if you're thinking like the facial muscles are a lump of clay, they are supporting the structure of the mouth, but it's the tongue that's the sculptor. So the tongue actually sculpts the way that the palate looks, the way that the airways open up, the sounds that we make with our mouth and our tongue, our sucking, swallowing, breathing habits, eating, speech, optimizing airways and respiration. So it's pretty important, the good old tongue. Now this is a big one, and I, was guilty for this. I thought that if the main requirement for a tongue tie that was dysfunctional was the fact that it didn't protrude. Now, this is something that's complete fallacy, because the protrusion of the tongue has little to do with most of the tongue's critical functions. And we could go into cranial nerve innervations, and also to the roles of the muscles, etc. But really, if you want to, go for gold on that stuff. But really, the tongue's actions is to elevate anteriorly and posteriorly, and to retract. So it does all of those features, not just protrude. So it is likely that tongue will be accompanied by an inability to retract and elevate, and therefore an inability to protrude remains the sign of dysfunction. So the first thing that we notice when there's dysfunction going on is in breastfeeding. So I think that breastfeeding really, unfortunately, and the stats are really proving that, that it is becoming a bit of a dying preferred way of feeding infants and children. And this is really, really sad. So I think, when you are talking the language of breastfeeding, some of these things can be really good to just actually talk to the mum about. And again, there's references on request if you need these, but basically just 4 simple things about benefits of breastfeeding: reduced rates of number of diseases, including childhood leukemia and cancers, reduced risk of obesity, which is a massive one, and significantly improves immune function. Again, a massive one. How many kids do we see with ENT issues? How many kids do we see with dysfunction in the airways? All of those sort of things. And also it contributes to allergy prevention, which again is huge in food intolerances that we're seeing with children. It minimises GIT issues such as constipation and other digestive issues. So when we're looking at the diagnosis of oral restrictions, you've really got to do a thorough history. So really get to know what's happening in breastfeeding. So we're looking for a poor or shallow latch, an excessive gag reflex. With this, the best way to do it is to actually have a look at the mum breastfeeding and observe these things. Because basically an excessive gag reflex, if we're looking at that one in isolation, the infant will be on high alert. So basically this Moro reflex will be going out of control. And basically, the child will not be able to hit the tongue away from the airway, so will gag and be very uncomfortable. Slides off the nipple after latching. Gumming and chewing of the nipple when nursing, so imagine like literally a gummy shark. That's how these children look with oral restrictions. Clicking when feeding, please, this is a big one to look for. So you get that intermittent loss of seal. The clicking takes place because the tongue's trying to snap back as the infant attempts to lift its restricted tongue. And because of obviously the restrictions, particularly in the tongue tie, and possibly the lip tie, this is what's happening. Just on that too, Dr. Monica, who's a dentist that we refer to now pretty much 99% of the time, her lactation consultant talks about that there's not really this thing of just a lip tie. There's always going to be a tongue tie association. And that's also too really, relevant in this point, because again, it's the overcompensating of the muscles that are around the tongue, and also to the tongue trying to do that job of lifting posteriorly and anteriorly, and also to retracting and protruding. So it's not able to do that, so it clicks. So again, with the lip tie, there's no flanging of the lip. There's no special K. So when I talk about the special K, we look at it from side on infant. This is something definitely I'd recommend Googling if you've never seen it before. But the lip should open up and be like a fat lip around the nipple. If it's not achieving that, it's not a special K. And basically there's going to be restrictions of most likely lip and tongue together. Possibly even buccal, which are the ones at the side we'll get into in a sec. They gag easily. Reflux, big one, okay, because again of the poor seal, and the lips don't flange, and so therefore the infant's actually swallowing a lot more air, and so therefore taking more fore milk and not taking as much hind milk. So they'll just be excessively uncomfortable because they've got none of that hind milk to fill them up, and they're just solely feeding on that fore milk, which as we know is mainly sugar, not the good fatty stuff. And so this then leads to the failure to thrive, etc. Now, the interesting thing too about the failure to thrive, this is a common association that we think when we look at breastfeeding and tongue tie, oral restrictions, etc. Bear in mind that basically most children, I say, and I don't have an actual statistic on this, but I'd say about 50-50 when we're looking at the stats, is that these babies will appear to be normal, appear to be growing, but they're not. They're not growing well because basically what's happening is they're feeding on that fore milk and the hind milk, and so not the nice fatty component of breast milk. Another big one is colic and excessive gas, and caused by what we see above. Okay, so other things to look at is vomiting, standard or frequent nursing, those babies that are constantly feeding, not a good thing. Falling asleep while nursing, and this is because of fatigue. Literally those muscles are working so damn hard to get that milk. So they become fatigued. Okay, you look at the size of a newborn stomach, first couple of months of life as well, very, very small. So any excessive exertion that they're having is going to cause them to fall asleep. And in that sleep too, because they're not full, because they're feeding on that full milk, they're going to have the short sleep episodes. Unable to hold a pacifier, so dummy in the mouth. Green feces, and again because they're feeding all on that full milk, It's a big one. Ask mum what colour is the child's poos. Okay, initially in the first couple of days of life, green is something that is quite normal. But then for a breastfeeding poo, it should be a nice mustardy yellow appearance. Definitely not green. And pulls away from the breast or arches during the feed. And we also know that's a massive issue with subluxation up in the neck and nerve irritation from that vagus nerve. So look for that. And also associated with that anterior shoulder, wrist, elbow, etc. from birth. Don't miss that. Okay. And these are the things too, through adjustments, that we can make a massive impact on, both before the release and after the release. My recommendation in terms of that is how often you should see them is really, hopefully, you've diagnosed this in your initial consult, you've referred out, hopefully they can get in generally within a week or two. In that time, you really should be seeing them twice a week, if not 3 times a week, depending on the restrictions that you find, and also to obviously your pre and post testing. But generally, again, think about an infant's neurology. It's changing every single minute to hour of the day. You want to make as much impact as you can in making sure that that body is developing properly. Okay, but bear in mind too, your adjustments will not hold if there is these oral restrictions. Okay, particularly the Shinzo reflex, it will stay as prevalent as it can when there's all this TMJ restriction. Okay. Alright, so again, mother's symptoms, you've got that crease or flattening nipples after nursing, cracked or blistered nipples, bruised nipples, blanched white nipples, pain, big one. Breastfeeding should not hurt. Okay, initially, first couple of days, yes, because you've got that contracting of the uterus after birth. After that, no. Okay. Use of nipple shields. Okay, this is a big one. Oh, my lactation consultant told me that I should have this. No. You're using a nipple shield as an adaptation for what is normal. Doesn't matter the size, shape, formation of your nipples. It's an adaptation. And again, it's usually some oral restriction that's been missed. So look out for that. Okay, and have the confidence to talk about that as well. And especially to get the mother thinking, well, this is a nipple shield. Yes, it may be aiding in your breast tissue, but why? Okay, have that confidence to do that, and write that in your referral to your dentist and also to your lactation consultant. Poor or incomplete breast drainage. So again, if we're only feeding on that hind milk, we're not getting to that full milk. Infected nipples, breast mastitis, nipple thrush, and low milk supply. This is a big one, low milk supply. So many women think they have low milk supply. They don't have a low milk supply. It's literally that they're, this is something that was raised at the last seminar that I went to, and it makes perfect sense, and this is not something I'd ever thought of. Usually what happens is, even with these oral restrictions, a mother will keep progressing with feeding for the first usually 3 to 4 months. The baby may not be failure to thrive, as I mentioned previously, but what's happening is, because they're supposed to be establishing this supply demand, it's not happening because they're feeding all on this formilk. So therefore the baby's having to just work for the formilk, not the hind milk. So when the hormonal response of breastfeeding stops around that 3 to 4 months, what happens? The mother suddenly has this low milk supply. No, the mother doesn't have a low milk supply. It's literally because these oral restrictions and attachment and subluxations that we see have been missed. Okay? Reaffirm that. How many mums out there blame themselves for their baby not being able to have enough milk? Okay? It's a big one. Alright, let's go into these types of oral restrictions. We've got the tongue tie, lip tie, and buccal ties, or buccal ties. Now there's lots of different classifications of, tongue ties, and there's no really right or wrong answer. To be honest, what Marjan has said is it doesn't really matter the type of classification. It's more about, is there a tongue tie there or not? Okay? So let's look at the normal range of motion. Okay? So again, there is devices out there that through, I forgot about that other seminar that I went to actually by a lactation consultant, Bridget, oh, I can't remember her surname, but I can get you the name if you want. She ran one in Brisbane. She was good. Not a big fan of talking about tongue ties, more just talking about attachment issues, which I don't know really how two and two can't go together. Bridget Ignall, that's her name, Bridget Ignall. And then Cherie is the dentist. Well, she's not a dentist actually, she's a myofascial specialist, which gives exercises for reshaping the jaw, etc. Okay, but look, to me, you know, as I said, it's not really important about the normal range of motion. As I said, you can measure it if you like. But just look, I mean, this is huge. The tongue goes out of the mouth, protrudes if we like, and goes up and touches the lip. Now again, you're not going to be getting a newborn doing that. But what you should see in a newborn is open the mouth and look, and that tongue should be nice and elevated anteriorly, posteriorly, and be able to move very freely. Okay, let's look at this class 1. Okay, mils wise, we're looking at 12 to 16. But again, see how the practitioner in this case has actually got the tongue? That's what you actually need to do. So you need to lift that tongue up and you need to see how much is there. See how it looks like more of a fascia response in here? So when I say fascia, all this droopy stuff here, okay? Now again, we'll talk about this in a sec, but there is no way a snip is going to get on top of that. So a cut with scissors versus a laser. A laser, again, 30 seconds to a minute in an infant will laser that whole response in here. Okay. Now when we look at class 2, we've got 8 to 12 millimeters. This is a moderate. Look at again the bandwidth of that frenulum. It's huge. Okay. And look, that tongue's hardly even lifting up at all. Okay. This is again when we're looking at a class 3, so this is a 4 to 8. Okay, there's literally no movement, so we're grasping the tongue on the outside and we're lifting up. Okay, Marjan also talks about depressing the actual tongue muscles at the back, so going in with like a kind of a peace sign, if you will, and actually going onto the back of the teeth, pushing down on the palate and seeing how much the tongue can then elevate. Okay, this practitioner's decided to do it from more of a pincer grip, and again I suppose that would work, but a lot more probably invasive on the infant. Okay, try both mechanisms, see which ones works for you, because again ultimately we just want to see that there is a tie there. Okay, this is going to be uncomfortable for the baby, adult or child, just so you know. And this is a complete one. You can see that there is literally no tongue movement here. This is a 0 to 4 mil. This is huge. I'm seeing these more and more though. Now the thing is the lip tie is actually the opposite. Okay, so when we're looking at class 1 is normal. Okay, class 2, and again we're looking here. There's no incisor impact, so again the lip tie doesn't go up and over. Okay. And again it goes just above the incisors, not actually under them. So this one actually goes up and under for a grade 3. Okay, so you again need to look inside the palate under here and see it goes actually into the anterior papilla, and it also too goes into those middle of the incisors. You can see it's already started to create a gap there, which aesthetically isn't great, and also functionally it's not going to flange that lip. This is the most severe and inserts into the anterior papilla, so literally there's just no movement there, and you can see even when you lift the lip there's hardly any movement. These buccal ties or buccal ties are definitely ones that are in contention, whether they're an issue or not. I believe they are, because I'm seeing it more and more when the tongue and lip have been released and there's still these big buccal ties. Again, the infant is not going to be able to attach well and create that flanging of the lip. Okay, don't be shy to talk about this with your dentist. Okay, hopefully you can establish that relationship that yes, there's not as much evidence with the buccal tie. However, what you're noticing is the mother's still complaining of pain, the infant's still got reflux, whatever it is. It hurts when breastfeeding is the big one. And I've seen about 3 or 4 mums that have complained of still pain after these two release. And when you look there, there's whopping buccal ties. So just keep that in mind. Okay, so what causes them? Okay, so the Darwinian theory. So the good old, you use it, you lose it type analogy. So again, because formula has become the norm, and even the stats say this, which is kind of scary, that basically what's happened is that the development and the widespread promotion of formula, coupled with the ability of the infant to feed more passively from a bottle, meant that infants who otherwise would have died, they've survived. So they pass on their genes, okay, which is kind of scary. The second theory is, again, the old MTFRH gene. All of you should be aware of this, hopefully, again, because we've done our basic AK, this will be mentioned. If you're not familiar with this, please do some research. One of my favourite physicians is Dr. Ben Lynch. He writes a book called Dirty Genes. Read it, YouTube it, podcast it, I don't care. Do something with it, because he's a phenomenal man in this gene expressions and mutations, and also to learning about the SNPs of the methylation cycle. Huge. Really great guy. He interviews a lot of paediatricians as well, which is great, and also like-minded doctors. So it's basically what happens is, and I won't go into this too much because again we should be aware of it, is that folic acid is synthetic. Okay, so this is a common ingredient in big market prenatals like Elevate. The biggest thing is it's synthetic, so we can't break it down in our methylation cycle. It needs to be in the active form and the more natural form, which is folate. Now again, these are generally practitioner brands, so every new mum that you've got coming into the practice, test for this MTFRH gene. We use Nutripath. You can do a blood test through Medicare, but honestly, it's a $50, $60 test. It's worth it. Okay. But to be honest, even without the MTFRH gene, which 70% of the population have, I'd still be taking folate. Okay. Because folic acid in those high doses, like for instance in Elevate, it's 900 micrograms, which is huge. And so with that high range, there's going to be bound to be issues. Essentially, folic acid was used as a prevention of spina bifida, and that works really great because really in 10 years in practice I've only seen one case. But midline defects are just becoming, just out of control. Okay, so cleft palates, tongue, lip, buccal ties are all becoming huge. This is a really interesting one, the third theory about congenital hypothyroidism. Okay, this is particularly a big thing between women postpartum and pregnancy. Definitely make sure a woman's thyroid is screened pre and post pregnancy. Huge. I just cannot harp on about this enough. Okay, because so many women, again, we know, go into adrenal fatigue and overload and all of those sort of things. But interesting enough, there's some research that shows the hypertonia of the tongue, and small mouths are products of small tongues, which is interesting. Okay, so how they treated. As I said, best approach is laser, okay, or ablation. Do not even look at cutting or snipping. The ablation doesn't crush or damage any of the matrix of the tissues being vaporized. So the area around the laser is less inflammation, less chance of reattachment. This is a huge one when active wound management stretches are applied and secondary intention healing occurs. So again, this active wound management, that's not something I believe is in our scope. Just make sure that they are doing it and really encourage them. Because in some older babies particularly, this can be very uncomfortable, okay, this wound management. Make sure it's done. And also, obviously, keeping up with your appointments and adjustments, etc. So how can a chiropractor help? I mean, there's lots of ways we know. We can help in gut management, we can help in, head position, we can help in vagus nerve rehab, we can help in torticollis, plagiocephaly, TMJ, the head bones are connected to the neck bones are connected to the shoulder bones, etc., etc., right? So the head bones, the cranial system, huge, huge. Do you think if you can get a cranial bone moving better, it's going to impact the cranial nerves? Absolutely. Okay. And again, CSF fluid, um, all of those things that we know that really impact from an adjustment. Okay. All right, these retained reflexes. Okay, these babies also too are going to be in a high Moro state. They're also probably going to couple with a fear paralysis, so have gut issues. Almost more than often, it's going to be both. Okay, check for the mouth reflexes. Know when these integrate, please. Okay, and make sure that they're integrated successfully. Okay, so gut health in infants and what does it mean to do with the oral restrictions? So again, we know that the vagus nerve helps is a complex process in your digestive tract. Um, it also too has a parasympathetic and also too a sympathetic component. We don't want that vagus nerve to override in the parasympathetic, the sympathetic response, because we know with the parasympathetic that's when our rest and digest happens. This is where we want a bubba to be, okay? We don't want these flighty flighty infants, okay? And so many of us see them, the classic irritable baby. This also too we know will be exacerbated with food restrictions, food intolerances, sensitivities, all of those things. Really, really important to look at, guys. And stress to the parents about this as well. Sorry, I keep flicking here. Yeah, this is a big one. Okay. And so again, later in children, okay, this is a big one. Of course, speech issues is something that we need to look at. Open mouth breathers. Oh, I can't testify this one enough. These are the kids that will not get that restful, nice REM cycle sleep. They'll end up with venous pooling, which is that nice dark circle under the eyes. They will just not grow properly because growth hormones excreted in that REM cycle sleep. If they're mouth breathing, the tongue doesn't go into the roof of the mouth, this doesn't allow to happen. They're going to be irritable, cranky, just all of the above, okay? Get parents to look and see if their infants and children are mouth or nose breathing, okay? In the infants as well, make sure that you can actually just get the parents to encourage that closure of the mouth, but again, make sure that oral restrictions and our subluxations have been restricted. Some just have been assessed, Some just need a little bit of extra training, okay? Low tongue posture, okay? So these are the kids, again, that don't have that nice wide maxilla, less space for the tongue, increased gag reflex, sleep apnea, poor sleep patterns, all of those sort of things. And the bones of the cranium are more likely to be locked up, twisted, again, contorted and dysfunctional, a result of dysfunctional growth. Okay. So any questions, feel free to always shoot me an email. My email is drlivscott, so that's drlivscott@gmail.com. And again, references are available on request if you guys would like them. Thanks for your attention tonight. Hope you've learnt something. As I said, this is a massive passion of mine, so I'm happy to help out whenever you guys need it. Okay, thank you very much. Chat soon.